Assalamu alaikum. Hello everyone. Hello great surgeons. Today we are going to start our first lecture for orthopedic. I will share the first slide for today. We will discuss ankle joint anatomy and some disorders. First of all, how is ankle joint is formed? It is formed by the end of the tibia. As you see, this is a bone which is found over the medial aspect over your leg, and the fibula is found over the lateral aspect of your leg. Then this is the anatomical interposition between end of the tibia and one of the tarsal bones. It is talus. One of tarsal bones, it is talus. So this is called tibio-talar joint. So ankle joint is called tibio-talar joint, where there is junction between tibia and talus. Then we have two subtypes of ankle fracture. One is called tilo fracture and one is called pilon fracture. Tilo fracture is a fracture of the distal tibial physis. This is fracture through the physeal plate of the distal tibia. While pilon is just a fracture distal to this physeal plate. You will see it at the bottom of the tibia. And usually this is involve the weight-bearing part of the ankle joint. Take care. You will have ankle injury or ankle joint trauma can occur equal in male and female, but it has a higher incidence in adult than young age and older age. This joint, when you are going to do imaging for it, you will use anteroposterior, lateral, and the mortise view. What is this mortise? This mortise is 20-degree internal rotation. 20-degree internal rotation view, which will show you the joint. We have also a very important landmark between talus and the calcaneus. This is found between talus and the calcaneus here. This is called a sinus tarsi. This sinus tarsi is just a space found between talus and calcaneus. Then we have ligamentous anatomy. What are the ligaments attached to the ankle joint? Medial aspect, lateral aspect, and at the level of the syndesmosis. Medial aspect, you have deltoid, and usually remember that you have medial aspect. This is the deltoid ligament. So deltoid ligament is related to the medial aspect of your leg, related to medial malleolus and the calcaneus from its medial aspect. This play very important role against valgus tilting of your talus. This is the valgus. Valgus is outside movement to your joint, and varus is inside movement to the joint. So once you are doing valgus, this is a resistance here over the medial aspect, which is the deltoid ligament. Then the lateral aspect. Lateral aspect, you have the lateral malleolus, you have the lower end of the fibula, and you have the calcaneus bone. So here, this is the talus and the calcaneus. Talus is forming also articulation with the fibula. As you see here, talus is forming articulation with the fibula. So here you have what's called anterior talofibular ligament, anterior talofibular ligament, then posterior talofibular ligament. Two ligaments related anterior and posterior to the talus, anterior talofibular and posterior talofibular. And you have posterior to the talus, you have, this is the calcaneus, as you see here. So calcaneus also can be related to the fibula and forming what's called calcaneofibular ligament. So over the lateral aspect, you have three ligaments: anterior talofibular, posterior talofibular, and the calcaneofibular ligament. Then we will go to the syndesmosis. Syndesmosis is the site where you have articulation between distal tibia and fibula. Distal tibia and fibula. especially the inferior tibiofibular ligament. Inferior tibiofibular ligament. This is the site of the syndesmosis. And this, you will have a complex of ligament related to it. You will have inferior tibiofibular, which is related to the tibia and the fibula. You have inferior tibiofibular, and this inferior tibiofibular ligament is divided into anterior and posterior. So you will have anterior inferior tibiofibular ligament and the posterior inferior tibiofibular ligament. And the ligament transversing between them, transverse tibiofibular ligament. So ligamentous anatomy is very important. On the medial aspect, MD, medial aspect is deltoid ligament and will protect against against valgus, excuse me. Then you have the lateral aspect. Lateral aspect where you have the talus is articulating with fibula, and you have also calcaneus with fibula. So talus with fibula will form anterior and posterior talofibular ligament. Then you have calcaneus with fibula, you will have calcaneofibular ligament. Over the syndesmosis, where you have the relation between lower end of fibula and lower end of tibia. You will have inferior tibiofibular ligament, which is divided into anterior and posterior, and you will have transverse tibiofibular ligament. These are all ankle ligaments, and this is the revision because they are already explained in lower limb anatomy. Next slide. This is on discussing the presentation of patient who is coming with ankle trauma. This patient will give you a history to trauma. It will be isolated to his ankle or maybe a part of generalized trauma. So you will go for your patient according to the ETLS, Advanced Trauma Life Support. This ETLS, you will start by assessing the patient airway, breathing, circulation, disability, and exposure. This ETLS, you will go for assessing the patient ABCD, airway, breathing, circulation, disability, and exposure. Then you will go, when you have open fracture, you will go according to post 4 principles. What are these posts? It is British Orthopedic Association of Standard of Trauma. British Orthopedic Association for Standard of Trauma. Those principles, you will follow them by giving the patient strong analgesia, immobilization of the joint. You will go for repair to any soft tissue injury and the bony injury and assessment of the neurovascular bundle. This will occur intraoperative. Then you will go for radiographic for the ankle joint, anteroposterior, lateral, and mortise view. And I say mortise view is 20-degree internal rotation. Take care. If you have an open fracture and you have soft tissue injury, please, you will have to irrigate this area with copious amount of normal saline. It will take up to 6 liters. And do not forget to debride any devitalized soft tissue, and you will assess the neuromuscular bundle. Also, the neurovascular bundle is very important because if you have arterial injury, you should manage this limb within 6 hours. Otherwise, you will have permanent disability and you will go for amputation. Here, we have 2 important classification for ankle fracture. First one is Lug-Hansen classification. Lug-Hansen classification, it has 2 parts. First part is the foot position. Second part is the force applied to it. So the position of the foot and the force applied to it. So this is collected into a single word, Sasir Babir. Sasir Babir. What is this Sasir and Babir? You will have here, first one, as you see, this is Lug-Hansen classification, as you see here. This is Sa, which is supination. Sasir, supination, adduction, and supination external rotation. This is Sasir. And you will have Papir, pronation, abduction, and the pronation external rotation. Here, you will have to predict the ligamentous or bony injury resulting from all of them. The highest incidence of ligamentous injury and bony injury is coming with cirrhosis, just with supination and external rotation. Keep this only information regarding Log-Hansen classification. What about Dennis-Weber classification? As you see, this is the Dennis-Weber classification. You will have type A, where there is a fracture below the syndesmosis, and type B, where there is a fracture at the level of the syndesmosis. And type C, you will have fracture above the level of the syndesmosis. And syndesmosis is just area of articulation with inferior tibiofibular ligament or tibiofibular joint. How will you manage your patient? Initially, I will go for what's called Dennis-Weber classification. Okay, then before Dennis-Weber classification, I have another type of fracture. It is called Messinov fracture. This Messinov fracture is commonly asked in Part B OSCE. When you are doing an ankle examination in an OSCE case, and you are doing ankle examination over medial, lateral malleolus, calcaneus, and you are going to tarsal and the metatarsal joint, and you are going varus and valgus stress test over the ankle joint. Don't forget to examine the proximal fibula. Why? Because you will have a Messinov fracture. What is Messinov fracture? Messinov fracture is fracture of the proximal fibula. Fracture of the proximal fibula. And may result in disability for the patient and instability of the superior tibiofibular ligament and also to the ankle. So let's go for management of Dennis-Weber fractures. First one, your patient will be either isolated or part of major trauma. So you will manage your patient according to ETLS. Then the specific management of the Weber classification depends on the stability of the joint. So usually type A fracture below the level of the syndesmosis, it will be stable. So your patient will just put an ankle boot. So your patient will just put an ankle boot. This ankle boot for about 6 weeks. So Weber B, which is usually at the level of the syndesmosis, may be stable or unstable. If unimalleolar, you will have only one of the malleoli, which is the lateral malleolus, is affected. So here you will go for conservative management like Weber A by ankle boot. But if you have associated bimalleolar or trimalleolar injury, which is just projecting posteriorly, so you will have a grade of instability. So please take care, you will have internal fixation. Weber C, usually, which is above of the syndesmosis level, this is usually a bimalleolar fracture, and you will have internal fixation in operative. So take care, Weber A, ankle boot. Weber B depends on the stability. If stable, ankle boot. If unstable, fixation. So Weber C, fixation always. Then take care. Stability and instability of the joint, either displaced or undisplaced. Take care. If you have, this is a new guideline, if you have a patient who has presented with displaced ankle joint, some surgeons go for conservative management. How is this come? This is a minor displacement or no major disability for the patient. So please, once you have a minor displacement, not a major displacement, take care. You can also go for conservative management by an ankle boot. Post-operative, you will follow your patient by his cast up to 6 weeks, and after it, you will go for physiotherapy. Next slide, by discussing avascular necrosis. What's the meaning of avascular necrosis? You will have interruption of the blood supply to the part of the bone. Take care. What is the difference between avascular necrosis and the non-union? You have many complications to bone, like malunion, where there is distorted union of the fracture. Non-union, where there is impaired union of the fracture. Avascular necrosis. Here you will have union of the fracture, but interruption of the blood supply to the joint. So here, your patient will present only by pain and the secondary osteoarthritis. Here, once you are doing X-ray, the joint is united, but you have slight areas of rarefaction due to impaired blood supply, and also you may find some areas of translucency due to secondary osteoarthritis. What are the bones which are liable to avascular necrosis? You will have scaphoid and leonate. Both are very important, especially in upper limb, scaphoid and leonate. And in lower limb, you will have talus and hip. Talus and hip. Causes of avascular necrosis are collected from the official site of the EMRCS into plastic rags. Plastic rags. Pancreatitis, lupus, alcohol, steroid and trauma, infection and casein disease, radiation or rheumatoid arthritis, amyloid Gaucher and sickle cell disease. Your patient will present late after an onset of fracture to any bone which is more liable to avascular necrosis. Here you will have severe pain, limitation of movement, also your fracture has been united. How will you investigate a case of avascular necrosis? By doing MRI. MRI early can detect the impaired blood supply to this area. Your management will be usually conservative, but take care that you should have a non-weight bearing. This will facilitate regeneration of the blood supply to this area which has interruption to its special blood supply. But if you have avascular necrosis, so here joint replacement may be necessary, and this is depending on the age of the patient. If you are talking about old age patient, and I am going to replace his joint, you will go hemiarthroplasty only or total hip replacement. If your patient is active and he is fit for anesthesia and he has no comorbidity and no cognitive disorder and his age is less than 65, go for total hip replacement. But if unfit for surgery, if has cognitive disorder, if he is unmobile, if he has also severe osteoarthritis and his age is more than 65, then go for hemiarthroplasty, total hip replacement. And we will go for this scheme for management of hip fracture in this lecture also. Next slide, we will discuss diseases of the vertebral column. From this page, I think 2 to 3 questions are coming each exam. First one, in discussing the ankylosing spondylitis. Ankylosing spondylitis, all of you know this disorder from rheumatology, that you will have a chronic inflammatory disorder affecting the axial skeleton. It will take from the thoracic, dorsal spine, and may reach up to sacrococcygeal. It starts as a sacroiliitis, where you have a pain at your lower back. Later on, you will have progressive limited mobility and the kyphosis of the patient. So your patient will present by loss of lumbar lordosis and the progressive kyphosis. Just a single word to be diagnostic for this ankylosing spondylitis. It will be positive HALA P27. Positive HALA P27, human leukocytic antigen P27. Then what is Sherman disease? This Sherman disease, this is a recurrent epiphysitis affecting the vertebral bones. How is this come? You will have the physis, epiphysis, and the metaphysis. You will have the epiphysitis, inflammation to the epiphyseal plate, especially within the vertebral joint. Here, your patient will have a slight distortion to the physeal plate. If you have distortion to the physeal plate, you will have prolapse to one vertebrae over the other, causing compression and anterior wedging. So your patient also will have a progressive kyphosis. This can occur in at least 3 successive vertebrae. Take care. That minor case should be managed with physiotherapy and analgesia. Then scoliosis and kyphosis. Scoliosis is lateral angulation of the vertebral column. Kyphosis is forward angulation of the vertebral column. Curvature lateral of the vertebral column is called scoliosis. This scoliosis is either structural and non-structural. Take care. What is the structural? Structural usually affect more than one vertebral body, and it has also three subtypes. Subtypes are idiopathic, congenital, and neuromuscular. You will have idiopathic, congenital, and neuromuscular. Take care that idiopathic is the most common type of the structural scoliosis. What about non-structural scoliosis? You will have non-structural scoliosis, which is common to occur in young age female. This is common in young age female. This is typically disappear when they are doing a maneuver. Typically disappear when they are doing maneuver, like bending forward. So scoliosis will be lost. Spina bifida dilemma. You will have three scenarios coming in exam. And the last scenario also came last April 2021 exam. You will have three scenarios on some defects of the neural arch. Some defects of the neural arch, like you will have only small defect of the neural arch with dimple of skin or tuft of hair, and no protrusion of any organ. This is called a spina bifida. You will have just only small defect of maturation of the neural arch, and you will have dimple over the skin or tuft of hair. Tuft of hair is a characteristic word for spina bifida. Keep this. So if you have defect of the neural arch and you will have only meninges coming from it, so this is called a meningeocele. 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 This is just a meninges are coming outside from the defect. But if you have meninges plus spinal cord is coming from the defect, and this is, by the way, is urgent, and this is life-saving for the patient, because you will have a paralysis for his both lower limbs if this is still in its space. This is called a meningomyelocele. Myelocele is the spinal cord protruding outside with its covering meninges. So meningeocele, meningomyelocele, and spina bifida occulta. Take care. Up to 10% of population have spina bifida occulta. Just your patient will present once at delivery by dimple over his skin at the lower back or just hair patch. What is the difference between spondylolysis and spondylolisthesis? Spondylolysis is just the deficiency of pars interarticularis of the neural arch of the vertebral body. You will have in the vertebral body, this is the body of the vertebrae, and it is related by a limb. Then you will have the transverse process. Then you will have another limb. Then you will have the posterior spine. Okay. Here you will have what's called the pedicle. The junction between body and pedicle and the transverse process, you will have area called pars interarticularis. Pars interarticularis, this area, if you have congenital or either acquired deficiency of these areas of pars interarticularis, you will have prolapse of one vertebrae over the other. You will have prolapse of one vertebrae over the other. Your patient will present by some manifestations of disc prolapse, but it is common at the level between L4 and 5. Up to 5% of population have spondylolysis. Spondylolysis, by the way, is the most common cause of spondylolisthesis in children. So spondylolysis is just a deficiency of pars interarticularis of the vertebrae. But spondylolisthesis is just movement of the above vertebrae over the other, causing compression also and wedging. So this is the difference between spondylolysis and spondylolisthesis. And here you will see spondylolisthesis, where you have just displaced the vertebrae over the other. On doing X-ray, you will have a very characteristic X-ray finding called a Scotty dog appearance. Scotty dog appearance. This is very important also for Part B OSCE. Commonly to be asked in Part B OSCE, but here just keep its name. No details needed for this Scotty dog, especially except in Part B OSCE. If your patient present by severe pain and the peripheral neurological manifestation, here we will need urgent spinal decompression and stabilization. Urgent spinal decompression and stabilization. This is very important. Then now, let's go for distal radial fractures. 3 names of distal radial fractures should be kept as your name. Colles fracture, Smith fracture, and the Barton fracture. Colles fracture is fracture of the distal radius. Here you will have dorsal tilting of the distal fragment. Dorsal tilting of the distal fragment. Very important to keep this. Colles fracture, the distal fragment here is dorsally tilted and also radially tilted. It will be dorsal above, and the radial means that lateral tilting. So once you are doing a reduction to this Colles fracture, what will you do? I will do volar compression and ulnar deviation. Volar compression and ulnar deviation to the distal fragment of the distal radius. So what is your management of a Colles fracture? Take care. You have a deformity related to Colles fracture called dinner fork deformity. Like your hand became like the dinner fork, like the fork. Your management is conservative. You will reduce it under what is called a Pierre block. Take care. This Pierre block, you will have a special type of anesthesia called prelocaine. Came in exam before. Colles fracture is commonly reduced under Pierre block, which is the regional anesthesia, by prelocaine. Prelocaine, keep its name, it is very important. What are the factors which are maintaining the instability to this Colles fracture? Take care if you have a dorsal tilt more than 20 degrees. If you have comminuted fracture, open skin. If you have injury to the ulnar styloid, this is the distal radius. If you have associated ulnar styloid fracture. If you have intra-articular disruption, like Barton fracture. So take care. Once you have Colles fracture, Smith fractures, they are extra-articular. But what about Barton fracture? It is intra-articular. Colles is dorsal angulation of the distal segment. Smith is volar angulation of the distal segment, like as you see here. But Barton fracture is an intra-articular fracture, which may be volar Barton or dorsal Barton. Volar Barton fracture is volar intra-articular distal radial fracture, while the dorsal Barton fracture is dorsal intra-articular fracture of the distal radius. So keep Colles, Smith, Barton fractures as your name. Some eponym fracture. We will have multiple names of fracture. Let's discuss first epiphyseal fracture, which is common in children. Classified by what's called Salter-Harris classification. Salter-Harris classification is very simple. As you see in this diagram, you will have here injury to the epiphysis. So once you have injury, transverse fracture through the gross plate. Once you have transverse fracture through the physis or the gross plate, this is type 1. What about type 5? Type 5 is compression fracture to the gross plate. So take care. On imaging, type 1 resembles type 5. So type 1 resembles type 5. But take care. The worst is type 5. So type 1 resembles type 5, because you have here transverse fracture through the gross plate in type 1 and the compression fracture through the gross plate also in type 5, but type 5 is the worst one. What about type 2, 3, 4? Type 2, you will have fracture against the metaphysis, while type 3, fracture to the epiphysis. What about type 4? Through the metaphysis and epiphysis. So again, type 2, this is the metaphysis. Type 3, how will you keep it? Type 3, you have double E, so this the epiphysis. While type 4 is combined type 2 and 3, this is the metaphysis and epiphysis. Two important questions regarding this. First one is type 1 resembles type 5 and the type 5 is the worst. Second question, type 2 is the commonest type where there is fracture through the metaphysis. Type 2 is the commonest type. Some eponym fracture. First one is a Colles fracture. We discussed it. It is a linear fork deformity, and you will have fracture of the distal radius proximal to the radiocarpal joint, dorsal displacement, and you will have radial tilting of the distal segment also. Smith fracture is also extra articular fracture of the distal radius, but you will have volar angulation. Is giving you another criteria called garden spade deformity. This is a reverse Colles fracture. This is a garden spade deformity. So dinner fork deformity for Colles fracture. Garden spade deformity for Smith fracture. Colles fracture and the Smith fracture is called reverse Colles fracture. Then next slide regarding continuing some eponym fracture. You have Butz fracture. We know Butz fracture is an intra-articular fracture which is affecting the ankle joint. This is the Butz fracture. We have triads, some triads of fracture. Pennant, Montigia, Galeazzi. Pennant, Montigia, Galeazzi. We have discussed the first triad of the distal radius. What is the first triad of the distal radius? You have Colles, Smith, and Barton. Then we have another triad, Pennant, Montigia, and Galeazzi. In past test, Pennant and Ronaldo fractures are discussed. What is the difference between Pennant and Ronaldo fracture? Both are fractures of the first metacarpopharyngeal joint. These are related to the base of the sub. So Pennant and Ronaldo related to the first metacarpopharyngeal joint. Excuse me, carpometacarpal joint. You will have, as you see into this picture, I will try to zoom over it. Pennant fracture, this is a simple fracture at the base of the first carpometacarpal joint. While Ronaldo fracture is a comminuted intra-articular fracture. So Pennant fracture is just a simple intra-articular carpometacarpal joint fracture at the base of the first carpometacarpal, while Ronaldo is a comminuted intra-articular fracture. So Pennant is simple, Ronaldo is comminuted. What about Montigia and Galeazzi? Remember this word, magar. What is this magar? I will see that Montigia is related to proximal ulnar fracture, while Galeazzi is related to distal radial fracture. So magar, M-U-G-R, Montigia is proximal ulnar, Galeazzi is distal radius. And Montigia is proximal ulnar with disruption to the proximal radioulnar joint, while Galeazzi is fracture to the distal radius with disruption to the distal radioulnar joint. Another last two types of fracture, they are Barton, and the Barton was from the triad of fractures of the distal radius, like Smith, Colles, and the Barton. And the Barton is an intra-articular fracture, which may be volar or dorsal. What about Holstein-Lewis fracture? Holstein-Lewis fracture is just asked once before in exams, not commonly recalled. But Holstein-Lewis fracture is fracture of the distal humerus. Fracture of the distal humerus. Take care. You will have entrapment to radial nerve. So fracture of the distal humerus causing entrapment to the radial nerve. Radial nerve, by the way, is giving you the extensor compartment over your forearm and acting also at the level of the elbow and wrist joint. So take care. If you have Holstein-Lewis fracture, fracture of the distal humerus, take care to assess the neurovascular bundle. If you have no affection of the radial joint, no affection of the brachial artery, so please go for reduction and conservative management. If you have vascular injury, so an open surgery is usually advised. Next, it will be on discussing some fracture management. Take care. What are the causes of fracture? Maybe trauma. And the trauma is usually an extensive force applied to the bone. But in some conditions, you will have stress fractures. Stress fractures is a minor trauma, but repeated, continuous, successive minor traumas causing fracture. Pathological fracture is fracture without anything due to reduced the position of osteoid material in the bone. This is the pathological fracture. How will you diagnose this? You will diagnose it by either you have history of trauma or not. You will have your patient coming by severe pain, which is localized in an area related to the bone and swelling. So pain and the swelling are very important criteria for presentation of fracture. You will go for imaging by doing X-ray. It will assess the type of fracture and its relation to the surrounding tissue, degree of angulation, and if you have any associated rotational effect, and how will this manage in your patient. Take care. Various types of fracture. First one is oblique fracture. Oblique fracture, which is passing obliquely through the long axis of the bone. Comminuted once you have more than 2 fragments. But if you have a friction of more than 1 fracture along the whole bone, this is called a segmental fracture, like a fracture proximal and the fracture distal. So this is called a segmental fracture. But if you have more than 2 segments of the bone are separated away, this is a comminuted fracture. Transverse fracture is just a fracture passing perpendicular to the long axis of bone, while spiral fracture is passing obliquely and rotation. Obliquely and rotation. What is the difference between open and closed? It is the skin. If you have injury to the skin at the site of the fracture, so this is an open fracture or comminuted fracture. For classification of open or comminuted fracture, you have Gastello-Anderson classification. Keep this as your name. Gastello-Anderson classification is very important. You have 3 grades, and the grade 3 is divided into 3 grades. First grade is that injury less than 1 centimeter. Second one, from 1 to 10 centimeter. Third one, it will be divided into A, B, C. A, you will have injury more than 10 centimeter, but with adequate soft tissue covering. B, you will have injury more than 10 centimeter, but without adequate soft tissue covering, and you will need immediate reconstruction. 3C, you will have affection to the vascular bundle. So you will have arterial or venous injury. How will you manage a fracture? When you see a patient who is coming with pain and swelling related to the site of the fracture, this may be isolated trauma or a part of generalized trauma, so I will manage my patient according to ATLS protocol. I will give the patient severe analgesia, severe potent analgesia. I will give the patient IV fluid, IV antibiotics, and the tetanus prophylaxis if I have a compound fracture. Do not forget to assess proximal and distal to the site of the fracture. Proximal and distal to the site of the fracture. Proximal assessment of the neurovascular bundle and distal assessment of the neurovascular bundle at the site of the fracture. Open comminuted fracture, usually you will need a lavage with copious amount of saline, which may reach up to 6 liters. You have 2 number of 6. 6 liters saline, this copious amount of normal saline for lavage of an area with comminuted fracture, and the 6th hour is the golden time where you should manage your patient if you have a neurovascular injury. So lavage with copious amount of the saline, 6 liters, and the managing of your patient within 6 hours. Next slide, we will discuss hip fracture, a major topic, very important, that you should know that the incidence of major hip fracture in the UK is reaching about 65,000 per year. 65,000 fracture of the hip per year. This is a very common topic asked in exam because it is very common to be seen in UK. It has a bimodal age, can be seen in adolescent and can be seen in old age. Take care. In young age and adolescent, you will need a high energy to cause this fracture. But in old age, just a low energy or either without any trauma. This is a pathological fracture. And your aim will be different from young age and old age. Young age, you will have a high energy trauma. So please take care. You should go for repair to this fracture, either operative or conservative, but mostly operative due to prolonged lifespan in order to reduce the morbidity and the mortality over this adolescent. But elderly patients, you have many of patients who are unfit for surgery, who have some cognitive impairment, who are already not mobile, who are more than 65. So you will go for minor surgical procedure or conservative management. In order to know anatomy, you will have the angle which is related between the femur itself and its neck. This angle is 130, may increase or decrease 7 degrees. Take care also that you have a slight anteversion by 7 degrees also. Then you have the vascular supply to the head of the femur. We have 3 arteries supplying the head of the femur. We have medial and lateral branches. They are called medial and lateral circumflex femoral arteries. Ascending branch and ascending branch. Ascending branch from medial and lateral circumflex femoral artery, and they are coming from profunda femoris, which is coming from the common femoral artery. So profunda femoris is a branch from common femoral artery and giving you medial and lateral circumflex femoral artery, and the medial and lateral circumflex femoral artery are giving you ascending branch. Then you have also some retinacular blood vessels. Some retinacular blood vessels also anastomosing at the level of the neck of the femur. And you have a fovea, which is an important landmark over the head of the femur. Fovea is supplied by the foveolar artery. Some are giving branches from the obturator, and some are saying that it is coming from the common femoral itself. So obturator or common femoral, you will have a foveolar artery, also a supply through the round ligament or ligamentum teres coming to the fovula. So if you have a fractured neck of the femur, how will you deal with it? Initially, take care that fractured pelvis and the femur are causing massive hemorrhage, and your patient may undergo into class 2 or 3 or even 4 hemorrhagic shock. So your patient should be immediately resuscitated with 1 liter crystalloid, Hartmann or Ringer lactate, and you should prepare blood for your patient. Do not forget to give your patient IV analgesia, IV antibiotics. If analgesia is not adequate, you may go for fascioiliacal nerve block. This is also a very common and added in this guidelines. How will you manage also hip fracture? We will go for this slide that we have what's called a Garden classification for fracture. This is the Garden classification. As you see here, we have type 1 and 2, type 3 and 4. Type 1 and 2, you will have no displacement. Type 3 and 4, you will have displacement. Type, okay. Then no displacement in type 1 and 2, you will have type 1, you will have incomplete fracture. but type 2 complete fracture. So type 1 incomplete non-displaced fracture. Type 2 complete non-displaced fracture. So this is type 1 and 2. This is easy. What about displaced fracture? Displaced fracture. This is type 3, displaced fracture less than 50%. While type 4 is displaced fracture more than 50%. This is called a Garden classification. Keep it again. Type 1 and 2 undisplaced. Type 3 and 4 displaced. Type 1 and 2. Type 1 incomplete. Type 2 complete fracture. While type 3 displacement less than 50%, while type 4 is displacement more than 50%. This is called a Garden classification. Garden classification. Imaging. You will go for imaging by X-ray, anteroposterior and lateral to the hip joint. Take care. Once you have a high suspicion of fracture and you will have X-rays normal, what's your next step? MRI. What's your next step? MRI. But if you have missed the first 24 hours and your patient is contraindicated for MRI, that this patient has claustrophobia, so please, you can go for CT. So when to go for CT? Once MRI is unavailable or once I have missed the first 24 hours. Classification, it can be classified into intracapsular or extracapsular. And because its management for each one is different, so we will keep them by STES. What is this STES? You have subcapital, transcervical, intertrochanteric, and hypertrochanteric, then subtrochanteric. Keep this STES as your name. First two are intracapsular. Last two are extracapsular. Again, STES, this is subcapital, transcervical, intertrochanteric or hypertrochanteric, then subtrochanteric. Subcapital, transcervical, they are intracapsular. Intertrochanteric, hypertrochanteric, subtrochanteric, they are extracapsular. So, any fracture neck of femur is classified into intracapsular and extracapsular. Take care. Intracapsular fracture are more liable to disruption to their blood supply, so they are more liable to avascular necrosis. Different classifications to intracapsular and extracapsular fractures. We discussed Garden classification for old age intracapsular, but we have another names only of fracture. Young intracapsular, you have Povil, intertrochanteric Evan, and subtrochanteric Russell-Taylor. Russell-Taylor for subtrochanteric fractures, just to keep their names only. When you manage your patient with fractured neck of femur, we have best practice tariff. Best practice tariff is giving you 36 hours to manage your patient with fractured femur. Take care not to increase management up to 48 hours. Why? You will increase the morbidity and the mortality to your patient, and your patient will be more liable to avascular necrosis. What's your management plan for this? I will put you on the route for this because they are very important. Let's go back to STES. First two, they are intracapsular. Last two, they are extracapsular. Subcapital, transcervical. Subcapital, transcervical, please go for total hip replacement. Subcapital and transcervical, intra-articular fractures, please go for total hip replacement. But what about the extra-articular fracture? If you have intertrochanteric or hypertrochanteric, or if you have subtrochanteric, intertrochanteric and hypertrochanteric, you will go for dynamic hip screw. But what about subtrochanteric? I will go for intramedullary. So keep this. If I have subcapital and transcervical, total hip replacement, extracapsular. If I have intertrochanteric, hypertrochanteric, dynamic hip screw, subtrochanteric, intramedullary nail. So these are the principles for management of hip fracture. Let's go for a detailed management for intracapsular and extracapsular fracture. And this is from the official site from EMRCS. For intracapsular fracture, what's your management? Your management immediately, either young age or old age, it will be internal fixation by cannulated screw. So, intracapsular fracture, I will go for cannulated screw. This is my main line of management, either young age or old age. So young age displaced or non-displaced, I will go for cannulated screw. Old age undisplaced, I will go for cannulated screw. But if displaced, and I have an old age patient, so displaced old age intracapsular, I have more susceptibility to avascular necrosis. So here we will stop. Old age and displaced. If your patient is less than 65 and your patient is mobile and is fit for surgery and has no cognitive impairment, go for total hip replacement. If the reverse, go for hemiarthroplasty. If your patient is more than 65 and not mobile and unfit for surgery and has some cognitive disability, so you will go for hemiarthroplasty. Again, this scheme is very important. If I have any intracapsular fracture, what's your management? It will be cannulated screw by internal fixation. So in young age, displaced and undisplaced, I will go for cannulated screw. But if I have old age, undisplaced, I will go for cannulated screw. Displaced, old age, intracapsular. So I have susceptibility to avascular necrosis. I will go. If my patient is young age, less than 65, or mobile, or has no cognitive disability, or this patient is fit for general anesthesia, I will go for total hip replacement. If my patient is not mobile, more than 65, and this patient has some cognitive disability and he is bedridden, unfit for general anesthesia, I will go for hemiarthroplasty. So this is very important classification for management of intracapsular fracture. What about extracapsular fracture? Extracapsular, we know it. This R, we have STIS. They are the I and S. I intertrochanteric or peritrochanteric, I will go for dynamic hip screw. Subtrochanteric, I will go for intramedullary nail. This is simple. But when you have intertrochanteric and you will go for intramedullary nail, just in two conditions. If I have unstable fracture or reverse oblique fracture, keep these two conditions. When to have intertrochanteric or peritrochanteric, and you will go for intramedullary nail, not dynamic hip screw. In two conditions only, if they are unstable or reverse oblique fracture. Here, you will go for intramedullary nail. Post-operative management, your patient will be in a cast for about 6 weeks and we will also be bedridden. After it, you will have to do physiotherapy and occupational therapy service. Occupational therapy service, OCT, is a big topic, also will be discussed in OSCE. Then now, let's discuss some knee collateral ligament. Knee collateral ligament, we have multiple ligaments related to the knee, and also discuss the lower limb anatomy. We have medial and lateral collateral ligament. We have medial and lateral menisci. And we have anterior and posterior cruciate ligaments. So we have 6 ligaments related. Medial and lateral collateral. Medial is called tibial collateral ligament, which is anatomically related from medial condyle of the femur to the medial aspect of the tibia. Lateral collateral ligament or fibular collateral ligament from lateral condyle of femur to the head of the fibula. Both of them play an important role in prevention of disruption of the joint on both sides. How will you test each one? I can test tibial collateral ligament or medial collateral ligament by doing what's called a valgus stress test. I will go valgus, I will go outside, do a valgus outside stress test. So I will do more and more tension over the medial aspect. So this is for testing the medial collateral ligament by valgus stress test. What about fibular collateral ligament or lateral collateral ligament? I will go for varus stress test by doing inward movement to your leg, and you will do stress over the lateral aspect of the knee. So valgus stress for medial collateral, varus stress for lateral collateral. Very important grading for the collateral ligament injury. Grade 1, 2, 3. Grade 1, you will have no instability but minor tear of the ligament. Here, you will go for conservative management. But if you have a slight disability, but once you do extension of the knee joint, you have stable. And you will have a ligament laxity. Ligament laxity can be seen in 30-degree flexion. So please go for splinting to this knee joint for 6 weeks. So if you have unstable knee joint, but stable only in extension, and you have ligament laxity on doing flexion, so please go for splinting for 6 weeks. But if you have unstable knee joint and you have complete laxity of the ligament or injury to the ligament, so surgical ligament reconstruction is advised. We will have rest for about 10 minutes, then we will go back. Now, let's discuss knee injuries. Different knee injuries are usually asked in exam. This page is extremely important. Keep it as your name. This page is really extremely important. We have anterior cruciate ligament, ACL ligament. If you have injury to ACL ligament or anterior cruciate ligament, this is coming as a forcible twisting to your knee. It will cause what's called a pop sound. So once you see a pop sound or forcible twisting to the knee, go for ACL rupture. What will happen? Immediate, rapid swelling to the knee. This is an hemoarthrosis. Take care. Once you have immediate swelling to the knee, pop sound, twisting injury to the knee, this is ACL. So immediate swelling is ACL. Pop sound is ACL. But if you have delayed swelling of the knee and the locking of your knee, that you have no immediately movement of your knee. And the delayed swelling. Delayed swelling means that your patient has trauma from 1 day, 2 days, or 1 week before, and now presented with just knee swelling and locking of the knee or unable to move his knee in any direction. So this is a meniscus injury. So the pop sound, you will have ACL injury and rapid joint swelling, hemoarthrosis. But lock joint and delayed swelling, this is a meniscus injury. Diagnosing ACL, anterior cruciate ligament. This is by 2 important tests. Keep their names only, but they are done in Part B OSCE in clinical examination station. In knee examination, you will do anterior drawer test and Lachman test. Anterior drawer and Lachman test. Both are very important for diagnosing the ACL rupture. PCL rupture, this is simple. You have posterior cruciate, so you should have extension, severe hyperextension over your knee. This is diagnosed by posterior drawer test. And you will see the tibia is pushing backward over the fibula. Rupture medial collateral, I said exposure to the medial collateral can be seen when you are doing a valgus stress test. Valgus stress test is that you are doing a force from outside to push the knee outside. To push the knee outside. And now you are doing stretch over the medial collateral ligament. Chondromalacia patelli, a common scenario in EMRCS. In a young age female who has a slight frequent injury to her patella due to severe going up and side down on the stairs. So once you see a teenage girl, young age female, has pain over her knee, this pain is coming on going downward, and a characteristic sign, it is a quadriceps twisting. So this is a chondromalacia patelli. So once you see a young age female, pain ongoing upstairs, and it can see it with examination of the quadriceps circumference, and you will see a quadriceps wasting. So this is a chondromalacia patella. What about dislocation and the fracture of the patella? Dislocation of the patella, this is common when you have a severe contraction of the quadriceps. This is an athlete who is doing a vigorous, severe contraction of the quadriceps, causing rupture to it and dislocation of the patella, usually associated with an osteochondral fracture. Two types of fracture patellae, direct blow, this is causing a still late fracture to the patella, and a vulgum fracture, which is common with severe contraction of the quadriceps. Tibial plateau, tibial plateau. Tibial plateau fracture, common in old age. Once you have any force to your knee causing valgus or varus, especially valgus. But if you have here, this is different from the collateral ligament. Take care, this is your post leg, this is thigh, and this is the leg. And this is also the thigh, and this is the leg. Here you have the medial collateral ligament on both sides. If you are doing a valgus stress outside, so you are doing stretch here, but you are doing compression here. So valgus stress will cause contraction or stretch over the medial collateral ligament and the compression over the lateral tibial plateau. And this is the reverse in varus, where you have movement of the leg inside. So you are doing extreme stretch of the lateral collateral ligament and the compression over the medial tibial plateau. So varus and valgus are causing different movement on the tibial plateau and on the collateral ligament injury. What is Shatsky classification of tibial plateau fracture? Shatsky classification, further details for it are not needed, but just to simplify them, you have 6 grades for fracture tibial plateau. Type 1, you have a vertical split of the lateral condyle. Type 2, you will have a vertical split of lateral condyle and you will have a slight load over this condyle. Type 3, you will have no fracture, just depression to the lateral condyle. Type 4 is medial condylar fracture. Type 5 is postcondyles, medial and lateral. Type 6, postcondyles and subcondylar fracture. I will show you Shatsky classification in a simple way. As you see here, this is lateral and this is medial, lateral with the fibula. You will have a vertical split of the lateral condyle. This is type 1. Vertical split and the slight compression of the lateral condyle. Type 3, no fracture, but just depression over lateral condyle. Type 4, vertical split of the medial condyle. Type 5, post, lateral condyle and the medial condyle. It should be here. While type 6, condyle with subcondylar fracture. So this is Shatsky classification of the tibial plateau fracture. Then let's go for open fracture. When to say open fracture? When I have a comminuted fracture associated with a skin injury. Gastello-Anderson classification, which is 3 types, and the type 3 is 3 types also. Type 1 less than 1 centimeter, type 2 from 2 to 10 centimeter, type 3, it is classified into EBC. E, you will have injury more than 10 centimeter, but with adequate soft tissue coverage. Type 3B, you will have injury more than 10 centimeter, but without adequate soft tissue covering, and you will need reconstruction. Type 3C, you will have associated vascular injury. In type 3C, you will go according to MES classification. What is MES? Mingled extremities scoring system. This a scoring system to assess you will go to reconstruct this limb or you will go for amputation. So if you have this score is high, I will go for amputation. Further details to this MES score are not needed for part B or even part A. We have 2-6 related to open fracture. Lavage of the area which is fractured by copious amount of saline, 6 liters. and you will have 6 hours to repair the vascular injury. This is all you should know about open fracture. Next, by discussing osteomalacia and osteoporosis. Osteomalacia, you will have normal bone, but decrease the mineral content. Decrease the mineral content. What is the difference between rickets and osteomalacia? Rickets, if you have ingrowing or ongoing child, but if you have after adolescence, after the physis has been fused, so this is called an osteomalacia. Osteomalacia due to vitamin D deficiency or even peripheral resistance, that you have normal vitamin D secretion and formation, but resistance to its peripheral action. Or you have renal failure, that you are not having the enzyme important to activate and form vitamin D. Liver disease, also if you have the enzyme responsible, which is 25 alpha hydroxylase in liver and 1 alpha hydroxylase in the kidney. Features. In rickets, you will see frontal bowing to the patient forehead, and you will see knock knee, that your patient has a geno valgus. Valgus, his both legs are outside and his both knee are coming inside toward. This the rickets. What about osteomalacia? Patient who is coming with proximal myopathy, coming with pathological fracture, generalized bony ache, and generalized muscle ache also. You will go for measurement of calcium, phosphate, and vitamin D. All will be low. But the characteristic here for osteomalacia that you will have elevated alkaline phosphatase. Very important criteria are found on X-ray. They are the same. They are called pseudofracture or loser zone or cortical infarction or Milkman line. All 4 names are the same. Pseudofracture, loser zone, cortical infarction, or Milkman line. You will see some areas of radiolucency, increase the bone deposition, and has sclerotic borders, but surrounded by areas not with bone deposition. So you will see transversal lucency and sclerotic border, and they are usually found perpendicular to the level of the bone. What's your management? It is calcium and vitamin D. I will try to show you what are the pseudofractures and the loser zones and Milkman lines. As you see into this picture, you have some areas, as you see, with radiolucency. As you see here, area of radiolucency, another area one of radiolucency. Then you have also here, and you have also here. These are areas of increased calcium deposition, but they are surrounded with areas of bone resorption. You will see here, there is extensive bone resorption in the bone, and here extensive bone resorption. Also, you have multiple patches of radio opaque. Then let's go for next slide on assessing the patient with osteoporosis. We have discussed osteomalacia, which is reduced mineralization. But what about osteoporosis? Osteoporosis, you will see a normal bone with normal mineralization, but you will have reduction of the amount of the deposited osteoid matrix. So reduced mineralization is a feature of osteomalacia, not osteoporosis. Because osteoporosis, you will have normal bone, normal mineralization, normal calcium, and reduce the amount of the osteoid matrix. So this is the difference between osteoporosis and osteomalacia. Osteoporosis can be diagnosed by a special investigation called DEXA scan. What is DEXA? It is dual emission X-ray absorptiometry. Absorption. Dual emission X-ray absorptiometry scanning. And you will go for assessment to the degree of bone osteoid matrix deposition according to what's called the T-score. You will have osteoporosis once you have a score less than or equal to 2.5. So osteoporosis will be assessed by the T-score according to DEXA scan. How will you manage a patient with osteoporosis? We have many lines of treatment. So first line, you can give the patient calcium and vitamin D. But take care, they are not the main line, because you will have to inhibit the osteoclast, which are causing the bone resorption, and you will have to stimulate the osteoblast, which are causing bone deposition. So you will inhibit the bone resorption by osteoclast inhibitor. What are the osteoclast inhibitor? They are bisphosphonates. What are these bisphosphonates? You have multiple drugs like alendronate, zolendronate, epandronate, and risedronate. Alendronate, epandronate, risedronate, and zolendronate, all zolendroic acid. Non-bisphosphonates. What are the non-bisphosphonates? You have raloxifene. Raloxifene is SERM, selective estrogen receptor modulator. Selective estrogen receptor modulator. And it can be used if you have any vertebral osteoporosis and not used in any non-vertebral osteoporosis. You have also teriparatide. Teriparatide is a paras hormone analog. You will give the patient a paras hormone analog to increase calcium in the blood. Hormone replacement therapy is the same like selective estrogen receptor modulator. Then, what are the NICE guidelines for management of the osteoporosis? They are updated in 2008. That you should follow this. You should stimulate the osteoblast and inhibit the osteoclast. Take care. Once you have osteoporosis, so your T-score is equal or less than 2.5. You will diagnose it by what's called DEXA scanning. Vitamin D and calcium should be offered to all women. Alendronate is your first line for management. Risedronate and etidronate can be given if your patient has side effects from alendronate. You have strontium ranelate. What is this strontium ranelate? It is a dual agent action. It has a dual agent action. It will stimulate the osteoblast to increase bone deposition, and it will inhibit the osteoclast to inhibit bone resorption. Raloxifene is a selective estrogen receptor modulator, will be discussed in next slide. Next slide, on discussing different guidelines, we have bisphosphonate. First, the bisphosphonate, we have pamidronate, etidronate, and zolendronate. Alendronate and risedronate are very important. But take care, once you have a side effects, you can go for risedronate and etidronate because alendronate is the first line for management. Take care, we have another one, is called epandronate, which can be used oral and it is once monthly. Raloxifene, selective estrogen receptor modulator, can be used especially in vertebral fracture, but not used in non-vertebral fracture. Take care, I am giving the patient estrogen. So it may worsen the menopausal symptoms and increase the risk of thromboembolic event and also increase the risk of ovarian and uterine carcinoma. Strontium ranelate, which is a dual agent action, act as a stimulation for osteoblast and inhibit the osteoclast. But also it increases the risk of thromboembolic agents or events, except like, especially like raloxifene. So better to put a plan for management of osteoporosis, it will be calcium, vitamin D, alendronate. If you have a vertebral fracture suspected in post-menopausal female, so please give the patient raloxifene with care because it may increase the thromboembolic events and it may increase incidence of ovarian and uterine cancer. We have finished our lecture today. Thank you all. See you and goodbye.